All right. Good morning, everyone. Um, on behalf of Screen NJ and Rutgers Cancer Institute, hello and welcome to Community Cares and Project Echo. Thank you so much for joining today's session, and we hope that the information shared today will help you serve your community better. We have a few announcements before we begin the presentation, and this is also just a quick reminder for the presentation, please keep your microphones muted. Until the end, we'll do a Q&A and you could unmute then. If you have any questions throughout the presentation, please put them in the chat. And we are recording today's webinar. So this is just a quick disclaimer that the information contained in this presentation is not substitute for medical consultation, and a physician should always be consulted for any health problem or medical condition. Today's agenda.
Can you come back?
So today's agenda, we're going to do a Project Echo series overview, introductions, the presentation, a case study, and at the end, we'll do questions and answers. So a little bit about Project Echo. Project Echo is a movement to demonopolize knowledge and amplify local capacity to provide best practice care for underserved people all over the world. The Echo model is committed to addressing the needs of the most vulnerable populations by equipping communities with the right knowledge at the right place at the right time. So for more information on Project Echo, you can go to echo.unm.edu. And this is the accreditation slide because today we are offering credits for continuing education credits for physicians, nurses, and social workers. But in order to receive those credits, I think it just kind of went fast. In order to receive those credits, you have to be on the Zoom the whole time, and you have to finish the evaluation at the end. So we'll pass that out at the end. We'll put it in the chat, and I'll also send an email sending that out as well. So without further ado, we have Dr. Gloria Bachman. Dr. Gloria Bachman is a nationally and internationally recognized physician who has moved healthcare to the next level in many areas. At Robert Wood Johnson University Hospital in New Brunswick, she is the attending physician in gynecology and the medical director of the Proud Gender Center at New Jersey. At Rutgers Robert Wood Johnson Medical School, she is the professor of OBGYN and medicine, the associate dean for women's health, and co-director of the Women's Health Institute. She is a respected clinician, a valued mentor, and a prolific researcher, and a sought-after educator. She has a long history of being the principal and co-principal investigator on several clinical trials, including federally funded NIH protocols. Data derived from her participation in multiple research trials has added extensively to the literature and to many advances in healthcare. She strongly advocates, especially underserved populations, for wellness screening, especially cancer screening, through not only clinical practice, but also through many educational tools that she oversees. So, for example, for previously incarcerated women, she has led the production of animated videos that educated reentry women on the need for breast, colon, and cervical cancer screening. She's a graduate of Rutgers University and received her MD from the Perelman School of Medicine and at the University of Pennsylvania. She also completed her OBGYN residency training at the University of Pennsylvania. So I know we have a pre-test that we'll be doing before the presentation. So if everybody wants to take a few minutes, just do the pre-test. We have a post-test too that we'll go over after. So if you want to just take a minute and complete the pre-test.
Sarah, I accidentally launched it early. Are people able to take the test?
No, Evelyn, it doesn't populate for me.
Okay, hold on. I'm going to launch the post test.
No, well, I don't know.
That's okay. We'll have at least one version.
Yeah. Oh, okay, people are answering. I couldn't see. Yeah.
And we'll just give it a minute for people to answer. Okay. All right, everyone. Thank you.
Okay, and I'm going to pass it to Dr. Bachman. Thank you, Dr. Bachman.
Well, first of all, I'm so happy to be with everyone, and this is this is a topic close to my heart because all of us are involved with everyday life with other individuals, and we've all experienced trauma or trauma in our colleagues and our friends and individuals who we care for. So it's a universal health issue versus not all of us have dealt with aortic stenosis or something like that. So trauma is universal, and I'm sure that all of us could really talk about some of the traumas that we've had. And I'm just going to start with the trauma that I had while I was still a learner. I was rounding with my team, and we suddenly heard screams from across the hospital hallway. And one of the individuals, one of the patients who we had just rounded on, had jumped out of the eighth floor window of the hospital. And I remember so vividly this traumatic event of all of our team running down the stairs to see if we could save this individual. And obviously, we couldn't. So, trauma is part of everyday living. And those of us who are in the healthcare field, we obviously see more than those who are not. So, let's go to the next slide. So these are some of what I'd like to go through today, and I don't have to read them to you. You could read them yourself, but it's really, there are hurdles of caring for patients who have been traumatized. And so what we'll do is we'll go through some of the ways to conduct a healthcare encounter. But again, we have to embrace that many individuals may not be ready to talk about the traumas that have occurred, but we have to open the door for them and basically relate to them that we are open to talking to them about their trauma, and then describe some of the specific needs of traumatized individuals so that we can give them the best care possible. What is trauma? And I think all of us have this definition pretty much embedded in our brains. It's an event or series of events experienced by any one of us that has lasting effects on our well-being. Now, these are really three important points that individuals may not recognize that they are in a traumatizing situation, especially for those in intimate family relationships where one of the individuals is being abused by another. It occurs everywhere, and including in hospital settings, and it can occur in any aspect of one's life, so including the work environment. And I think that the example that comes to my mind, and probably to many of your mind, is the recent trauma that we had with COVID, where we had to wear masks, where we really couldn't socialize, and so forth and so on. So these things do happen in our everyday life, as well as in certain situations that we encounter as the healthcare team. So what qualifies as trauma? And I think sometimes we don't think of these. For instance, it doesn't come up naturally to me that a natural disaster is a trauma because I've never been in anything that has affected me. I've been safe during hurricanes. I've never been in an earthquake, and I've never been in a flood. Caring for individuals in adverse or dangerous environments. And as you could see, the emergency response setting is one such traumatic setting. Acts of violence. We've all been in a personal accident. I'm sure most of us in our cars have experienced an accident, and living in an environment, which is what we just talked about, where there's physical, sexual, or emotional abuse or violence. And I see this very often when I go to the Edna Mahan Correctional Center, and I meet with the women there, that many of them were living in an environment where there was this type of trauma. So responses to trauma include feelings of fear, of panic, that recurrent nightmares, and that for many individuals never goes away. That they think about this traumatic event for basically the rest of their life. That it, like the event that I saw with the individual jumping out of the window of the hospital, I still think about it. It doesn't go away. So, what is trauma-informed care? And I think this is what we all want to do. We want to deliver optimal health care. And we basically have to know where the individual who we're caring for, what their life experiences are. And many times they may not be that forthcoming in telling us. So, what I emphasize and what the most important aspect of trauma-informed care is optimal health care involves not assuming an individual has not had trauma, has had significant trauma if they don't report it. There are many individuals who are really reluctant to talk about the traumas that they've been experiencing or that they had experienced. So to provide trauma-informed care, the individual must feel comfortable, very comfortable in giving this. So we many times don't recognize it. What we think about trauma is we think of this, right? Raise your hand. Isn't this what you think about when you think of trauma? Next. You don't think of this. These individuals look perfectly okay. And again, the only one that you would probably think there's trauma involved is in the lower picture, right? Where the individual looks distressed. But it doesn't mean that the trauma has not occurred in the other two individuals. So we don't always recognize the trauma just by looking at or visualizing the individual. That in the third picture on the bottom, we would definitely say, gee, was there trauma? But in the other two, we might not. So these are some tests for you because trauma does not always present so visually. What do you see when you look at this picture? And again, this is just putting our thinking caps on to say we have to really be open to trauma. What do you see? So what's the answer? Do you see a rabbit or do you see a duck? I see a duck. So again, we see different things. I'm sure some of you saw a rabbit first, but I saw a duck. Next. What do you see here? Put your thinking caps on. Okay, next slide. So we'll give the answers. How many of you saw a man's face? You did. Okay, I saw a shepherd on a farm. So I did not see the man's face first. So again, each individual who we see, we will see differently as providers. And obviously, the right answer is sometimes not directly in front of us, but we have to open ourselves to that individual coming back and saying, if they're not really comfortable the first time, yes, I have had traumatic events or I'm experiencing traumatic events. Next. So what do you see here? And I think this one is pretty obvious. Let's have the answers. Did any of you see a horse? I didn't. I see the frog because it's so obvious. And I think this is the best example, unless you saw the horse first. We just see what we want to see many times. I definitely saw the frog, but raise your hand. Did anybody see the horse first? No. But let's go to the next slide. If it were presented this way, then obviously very clear. I don't see the frog anymore. I see only the horse. So people present different ways. And this is why I'm showing these to you, that it's not so obvious. And with one encounter, you may see the frog. With the other encounter, you may see the horse, which is the traumatized individual. Now, this is a really, really difficult one. And I think I bring this up because it's very difficult sometimes to really evaluate someone for trauma if we don't see it that clearly. How many of you can find the hidden tiger? I would really like to hear if anybody can find the hidden tiger. Okay, we have a lot of people who see the hidden tiger. I never saw it when I first looked at this, but there's many of you who have seen it. Let's go to the next slide and we'll get the answer. It's in the tiger's stripes. So I was looking all over the environment, into the trees, into the bushes, into the ground. I never thought of looking in the tiger's stripes. So again, this is just emphasizing how we have to be really open to evaluating the individuals who we care for in comprehensive ways that are not always the first way that we think about talking to an individual or evaluating an individual, that there may be other ways that we're not thinking of. And I think this is a good example that, again, many of you did see the tiger, but I did not see the tiger. I looked at the scenery, but I did not look at the stripes. Next. Now, this is a hard one. Are these identical? So again, it shows that how we look at an individual is not always so obvious as to what's going on, because this is not so obvious. Okay, raise your hand. Are these Mona Lisas identical? Nobody. Are these Mona Lisas not identical? Raise your hand. All right, wow. This is a phenomenal group. So next slide. They're not. So you can see that when we turn something around, when we look at something in another way, it becomes so much more obvious that it wasn't that obvious when we had her turned around. But when we put Da Vinci's painting the other way, we could see that, yes, these are different pictures of the Mona Lisa. And as someone put in the chat, the eyes are different. So that one has, and then even the smile is different, that you could see this one has a little bit of a frown and the other has a little smirk. So next slide. So I think Albert Einstein says it best. And I like this quote because it's not that I'm so smart, and we all think of Albert Einstein as a genius. I mean, jeepers creepers. He was amazing, but it's just that I stay with the problem longer. And I think that's really what we have to do, that we have to make sure that we're putting our thinking caps on, that we're staying with the problem, and that we're really addressing all aspects of it rather than just direct. And I just see this from Evelyn. Any questions, please feel free to use the chat. We will address all questions afterwards. So why is trauma-informed healthcare in clinical settings so important? Well, this is it. Improves patient engagement, treatment adherence, health outcomes, as well as our own wellness, provider and staff wellness. So let's look at some of the statistics. And these are the statistics that I don't have to read to you. But it's fairly common. There's a wide range of behaviors. And I think in some scenarios, it might not be considered domestic violence if slapping is part of, what everybody did in the family. You may not consider being slapped a adverse behavior from someone slapping you. And then the most obvious that we have to be very, very concerned about is 1 in 7 and 1 in 25 men have been injured by an intimate partner. So adverse consequences do result. And these are heartbreaking. Over a third of all murders of women are committed by an intimate partner, and 55% of all homicides are intimate partner violence related. So we have to stop this cycle. Next. So women with trauma backgrounds are more commonly in prison. And I already spoke about this, and you could read this yourself. But when I go to the Edna Mahan, this is basically what I see. And this is not just in one particular area of the world, it's in all areas of the world. A United Nations report noted that 70% of women convicted of killing a spouse or family member had experienced long-standing pattern of physical abuse or forced economic dependence. So that this is basically something that you finally react to, that something is the trigger, or that you're being slapped and it really hurts and you slap back. Similar statistics are noted in many, many countries. And as you can see, Jordan, South Africa, the United States, Argentina, common in the prison system, as well as in the non-prison system. And this is a graph that you can see. So what's happening? What do you see here? What is the, put in the chat, what do you see here? I'll give you a second. What's happening? Anybody? Put in the chat what you see. Increased, yes. In both state, federal prisons, there is an increase in incarcerated individual with women. That this is not decreasing, which is what we would like to see, but it's actually increasing over time. And it's very disturbing to see this, that this has actually happened. And somebody put it, if women's crimes are growing, then trauma against women is increasing. That's from Sharon. And absolutely, absolutely. And that's why it's so important for all of us to really put on our global hat of let's take in everything with this individual to make sure that this person is not in this type of situation. Next. So this is what I was talking about already, and you could read it. I go up to Edna Mahan at least once a month, and I meet with the women. And so I see this firsthand. So this is very disturbing. So the point that I think this really emphasizes is that nearly 1/3 or 33% have had emotional, physical, and sexual abuse and trauma. 1/3 at our correctional facility at Edna Mahan. And this is from New Jersey, and I'm sure if we had Pennsylvania data, if we had data from European countries or Asian countries, we would see this same type of report. That many of the individuals in incarceration settings have had abuse and trauma, especially for women. Next. Now, this can apply to everyone. It's not just physicians, it's to the whole healthcare team. And I just brought this up because instead of reading it as U.S. physicians, I'd like you to read it as the healthcare team. That how many of you could think back to the COVID-19 pandemic? And I'd like to put in the chat, how many of you were traumatized by it? And we talked a little bit about this already. Raise your hand. I was traumatized by it. Yeah. Yes. Very, very traumatic. And some of us still live with that trauma. Sometimes when I see someone wearing a face mask on a city street, I like think back to the COVID. And these are some of the other statistics. And again, we don't have to put this as physicians, but any healthcare provider, any healthcare worker, any healthcare team member. The burnout, almost 2/3 of healthcare providers with COVID burnout due to pandemic related stress. Many of the clinicians left current practice, as well as nurses and other healthcare providers. And as the U.S. entered winter months of the COVID, physicians continuously reported increased rates of stress and burnout. And again, you could replace physician with any healthcare team member. That this was a very, very stressful time for everyone. And again, think back for just a second to your own stress during this time. How many of you just felt so alone when you couldn't get together with colleagues or friends? I did. Anybody else feel like being isolated and traumatic that, gee, I can't see my best friend because of the COVID? Yeah, I remember we didn't know if it was safe to bring the groceries inside without spraying them. Exactly. So this is some more data that you could read. And again, you can replace this with any healthcare provider. So there was the inadequate funding for adequate medical staffing, lack of appreciation, malpractice, lack of confidence in U.S. public health, and 2022 Medscape National Physician Burnout and Suicide Rates, that 10% of physicians had suicide rates. But I think this can again be any healthcare provider that you just feel so traumatized, you have burnout, you're stressed, and it's really very sad to see that 1 in 10 had suicidal thoughts. Think about that for a minute. 1 in 10. That is a high, high number. Very high. And it's one that we don't want to see, that we don't want to have anyone have to feel that, that they're just so traumatized that they hardly can live every day without having suicidal thoughts. Next. So what are the 4 R's? I'm going to give you a chance to read them yourself because this is what we do. This is what we do as the healthcare team. And this is what we're going through today to realize the widespread impact of trauma and really understand potential paths for recovery. Recognizing it. And the point that I want to bring back up here is it's not just in our clients, but in our colleagues and our staff to help them as well. Responding by fully integrating knowledge. And then seek actively ways to prevent recurrence. How many of you look for trauma in your team members? Okay, there's a few, and some say rarely. If now, this is the question I want you now to answer. How many of you would act on it if you said, "Gee, Gloria Bachman, you look so stressed. Is there anything I can do?" How many of you would intervene? Phenomenal. Phenomenal. That that's really we have to do that. We have to intervene. We have to, it's always nice to have somebody rub your shoulder and say, "Are you okay?" Next. And these are some of the going through the R's. So it's not only in the outside the healthcare setting, but in the healthcare setting. And I think I started this talk with I had trauma in the healthcare setting when I was rounding, and one of the patients committed suicide by jumping out of the window. And I could still see the entire scenario of what happened that day. And it is a traumatic event in the healthcare setting. Okay, this is recognize. Now, this is important. And I think obviously repeated clinic visits, vague complaints, over controlling partner. And how many of you have any input into emergency room? I usually don't. Does anybody here have in work in near or with an emergency room? This is really one of the first places that sometimes you can make the diagnosis. Somebody with multiple ER visits with bruising where they say they fell, and the bruising is not compatible with them falling. And these are some of the for our healthcare. These are some of them. Now you don't have to put your name to it, but how many of you did feel burnout or exhaustion, or see burnout or exhaustion of your colleagues? I mean, that's important to know. Mm-hmm. Yep. Some of you have, yes. And sometimes when we say, "Gee, this person's not really doing the best job," maybe they're not doing the best job because they themselves have been traumatized and they're dealing with post-traumatic stress. And but a lot of people don't say it. A lot of people don't say that they have burnout or they're exhausted. So the other thing is it's okay to say. You don't have to hide something. "Oh, I just am so exhausted. I need some time off," or whatever it is, but it's okay. It's okay. Next. Respond and respond. When interviewing the victim, separate the victim from all others who come in. Why is that important? Anybody want to put it in the chat? Why that is important? All of these are important points, but anybody want to put in the chat why you have to separate the victim from all others who come in with them? So psychological safety, you don't want safety, avoid trauma bonding. Keep going. We didn't come up with the right answer yet. Privacy. Somebody just said it. They may be the source of the trauma. So that if I, Gloria Bachman, come in with a person, either my spouse or a sibling, and they're sitting there and I'm asked, "Gee, do I have any traumatic experiences or events?" I look at that person And I know that I'll be more traumatized if I say yes. More traumatized if I say yes. So you have to be sure that you give the individual the privacy that they must have to be able to express. And for you to tell them, it just stays with you. It doesn't go anyplace else. You don't talk to a partner, to a sibling, to a parent, or anyone else, but that this is very private, confidential healthcare information, which HIPAA says all of us have to have confidential information. So that's why we wait. Now go back to that slide. I want to go back to a few more things. So in the clinical setting, these are the things. Focus your questions, be specific, be supportive. Don't say, why do you put up with that? What's wrong with you? Aren't you an adult? No, we would never say that. But I certainly understand the stress that you have. Don't get bogged down by trying to determine the motivation of the abuser. Don't start saying, well, why does that person abuse you? What are you doing? No, that's not what we do. Don't get bogged down by trying to determine the person is being abused, is in a traumatic experience. You don't do that. And acknowledge the victim's fears. Like, are you concerned about entering your home? Are you concerned that something violent may happen there to either you or someone else in the home? So this is the responding. Next. And the re-traumatization. So this is really where you're addressing the trauma and trying. I mean, we can't do everything, but we could do as much as possible and connect with the right resources for that individual. So implementing the steps. So I, Gloria Bachman, may not be able to do it all. That it's just impossible for me to do it all. But I may go to Sarah, I may go to Evelyn, I may go to Gabrielle, I may go to others and say, let's work together to see how we can best help this individual so that re-traumatization does not occur. And then in clinical settings, this means, oops, go back. Oh, okay. Stopping the exam. I've had to stop the exam many, many times in individuals, especially when I'm doing a pap test, that it's very uncomfortable, that it's very traumatizing. And so what I say before the pelvic is, I am going to listen to you and your feedback. If you tell me to stop, I immediately stop. No questions asked. Not like, oh, it's only going to be another 2 minutes. Oh, what are you upset about? Or why is it so uncomfortable? But that's really important. Patient participation in the exam, agree to defer uncomfortable portions. So if the patient says, well, I really don't want to have my abdomen checked today. It's so sore and I've had a lot of GI upset. That's fine. Privacy. We talked about the privacy already. And what would you do before you allowed a trusted friend or family member be present? What would you do first? If I came and I said, and you said, "Is this a trusted friend?" I'm with a neighbor, and I said yes. What would be wrong with that scenario? What did I do incorrectly? Yes, I asked in front of the patient. And remember, we talked about giving the patient privacy first. So Gloria Bachman should have been, without that neighbor present, asked, do you want the neighbor to stay with you? And I would say, no, because they're part of my trauma. So allowing a trusted friend or family member to be present, you have to ask that individual without that friend or family member present. And that's another key takeaway from this echo talk. Make sure that you've okayed it with that individual. Next. So I think as we talk about what can we do, first of all, not one of us can eliminate all the suffering of others. And we see this every day, not only in our healthcare setting, in our professional setting, in our neighborhood, in our family. We cannot do that. But we really want to encourage the healing process. We want to take part in the healing process. We want to try to ameliorate as much of the pain as we possibly can. Doesn't mean that we can be totally effective, but eliminate as much as we can. And I think we already talked about this, and I think many of you said it. Check in with colleagues who have had difficult clinical scenarios with patient loss and or adverse clinical or operative outcomes. And this is really important. And I'll go back to my own scenario, that after this happened, we did all get together. We all sat down in a circle and we talked about the traumatic event with seeing one of our patients who was obviously so distressed commit suicide. So basically, it's really, really important to be able to join together, to hold hands, basically. And it's also okay to check in with colleagues who are dealing with personal issues. That if you have a colleague, who has a child with a life-threatening illness, it's okay to say, "Is there anything I could do for you? Can I help in any way?" So it's okay to check in, especially if they are dealing with family, with personal issues, even with work-related issues. It's okay to check in. Next. So stimulate renewal by taking the time to mourn for what might have been lost and to look ahead in the pursuit of possibilities that have not yet been realized. Provide compassionate and empathy in the period following a crisis. And this is what we did on the floor. And as Milner and Echterling wrote, the act of bearing witness as an empathetic, attuned, active listener is a powerful intervention in and of itself. So being there, just being present, can help that individual in trauma-informed care. You don't have to know a lot about that individual. You don't have to know all the circumstances. You don't have to get into the details, but just being there and being an active listener. And this is with anyone, with a colleague, with a friend, or with anyone who we are caring for. Being an active, empathetic, attuned listener is so critical. Next. So this is the summary, and we have about 10 minutes for wrap up and everything. Trauma-informed care should be offered to all at-risk traumatized individuals, and that means that we have to identify many times who those individuals are. That when we saw those pictures of those individuals that had bruises on their face, it was very clear that they had been traumatized, whether they were in a car accident, whether they were beaten up, whatever, versus just looking at me, Gloria Bachman, that doesn't have any obvious bruises and saying, well, she's not been traumatized. Well, maybe I have been traumatized. Maybe that's affecting my health, my emotional well-being, my ability to stick to the medication regimen that I should be on. So you may not recognize it, but you should be attuned to anything that the patient or the individual or the colleague or the friend or the family member may say that would say, gee, they have been traumatized. And individuals, then this is really the summary. Individuals benefiting from trauma-informed care may not present in one uniform way. So we already talked about that we all, probably every single one of us on this call would present in a slightly different way. That we would not all be saying, oh, I just had the worst car accident ever. I still imagine this car crashing into me and my airbag going off and oh, it was horrible. Versus, how you doing? I'm doing okay. Anything happened to you recently? Just, just a car accident. So everybody presents differently, not in one uniform way. And I think it's being open to dialogue, being empathetic, and showing that you're there for the patient and for the colleague and for the family member and for anyone who you see is suffering or not suffering, but just acting in a way that is not typical for them, is basically those that you should try to identify what's going on and offer them the trauma-informed care that we talked about during this session. Okay? So this is the case study. She was the prototype of a healthy person. And, there's no bruising, there's nothing going on. She presented for a general GYN checkup, and her only complaint was pelvic pain. Now, again, both men and women can have pelvic pain, but it's more common in women because of ovulation, because of the uterus and fibroids, because of pelvic inflammatory disease, and so forth and so on. So it's a common complaint. And she noted that the pain was there for several months. So she's finally coming in for the general checkup, and she says, I've had pain down in my lower abdomen for several months. Next. So what is the key question you wish to have answered in presenting this case? So she did not complain of experiencing trauma in her home. Her only complaint was the pelvic pain. So how does one transition to asking about potential trauma? Think about it for a couple of minutes. And if anybody would like to put it in the chat, or sexually active with who? Is it painful? Okay, that's important. That's very important. Whether she's sexually active and is there pain with sexual activity. And again, we also have to understand what kind of sexual activity the individual is participating in. That whether it's in a heterosexual relationship, a homosexual relationship, etc. Any other thoughts? When did it start? And do you know what may have caused it? Okay. So that's also very important. Very important. Well, I had a bad infection, a bad infection, and that's when the pain started. So what would you think of if someone said I had a bad infection? Anybody? Well, first asking the patient about possible cause, and was it sexually transmitted, and how did you get it? Yep. Was it sexually transmitted? Did you get treatment for it? And the patient may say, well, no, I really didn't. I just was afraid to go for treatment. And was your partner tested? Again, that's important. Was your partner tested? So this could be pelvic inflammatory disease. Could explain that because emotional distress sometimes presents in the body. So this could also be emotional, that there has been sexual trauma with a partner. And so therefore the answer to basically not interacting with that partner sexually might be having pelvic pain. And is your partner aware? Oh, and then foreign body. Is there a foreign body that is causing the pelvic pain? So you're asking patients more about medical history of previous pelvic issues. So yes, and that's why there's a lot of questions and comments. That's why it's important to take time when you're talking to anyone. Now, what would you say if you're talking to me and you really have to get to another appointment that you can't be late? Would you say as you dig deeper, she may open up more? Absolutely. But let's say you had to leave me and you couldn't answer all my questions. What would you say to me? Like, I have pelvic pain and you really have to get on to another event that you cannot be late for. What would you say to me to close the conversation? Anybody? This is important. Can I see you again or call you later? Absolutely. So seeing you again, I'm so sorry. I'm really, really, I want to help you. But at this point, I have to take off. But you can call me later or set up another appointment. Yes, I would like to continue speaking with you. However, I'll call you later. I'll make an appointment. So you don't close that encounter with, well, it's too bad. Let's talk about it next time. Just make an appointment and we'll talk about it. But rather that you do care, that you want continuity of care, and that you are there for the patient. Absolutely. Next. Okay, so what are the metrics of implementations? Data suggests that asking questions about trauma as part of the intake questions and part of the history normalize the questions. So what you can say first is, I'm asking you this question, and I ask all patients this question. I ask all clients this question. I ask all my friends this question. I ask all my family members, whatever it is. Individuals have a significant other in the room, may not want to share. And we said this many times, is that person may be the person causing their trauma. So again, we have to make sure that we give privacy. And in these cases, it's best to either note that you have to bring the patient to another room for any reason. Oh, wait, we have to get something else signed. Can you come with me for a second? Even if it's not necessary to have time alone with the patient, with the client, with your friend, so that you do have time alone. And as we already mentioned, this is so key because of the issues that trauma may occur with someone that the individual knows. Next. So what changes would you like to see addressed? The first change is to normalize the traumatic life events that can happen to anyone. It does not mean that the individual experiencing this scenario is a lesser person for it. In some occupations that the trauma is more common than in others. And our veterans are very high risk for post-traumatic stress disorder. For those of you who don't know this, there is a site in Carteret, New Jersey, where there are a lot of veterans, and this is seen, the post-traumatic stress disorder among the veterans. So that has to be addressed with our veterans, who many times have been in scenarios that are very stressful. Next. Okay, so here's a Q&A forum, and we have 3 minutes, but I think Evelyn or Sarah will tell me when the time is up.
Yeah, so I'm thinking, do you want for this portion, should we have them unmute if they want to speak up? We'll only do a few because we have the post test to do after.
Okay, maybe we don't have the Q&A. Let's do the post test, and then if we have, because we have 3 minutes. So let's go to the post test.
Okay. Evelyn, are we able to launch it again or no? Oh, yeah. So take a second and finish the post test, and then I have the answers on the next slide.
Give it about another 30 seconds. All the answers are coming in.
Good.
Sorry, I have a barky dog in the background. Somebody's hungry for second breakfast.
I can't hear your dog.
Oh,
So
okay, good. All right, if we get a few more people. Okay, in the essence of time, I'm going to go ahead and end the poll.
okay, so let me go through the answers. The patient with a traumatic life event presents differently. And it is true. It could be true and it could be false that they may present as very anxious, very, oh, I can't take it anymore. Or they may present as any one of us who have not been traumatized, um, just as an average person, but there is a traumatic events going on in their life. So it can be true or false, but basically, many times they don't present differently. And approximately the same percentage of men and women experience ongoing trauma. It really is that women do appear to have more trauma than men do. So that this one is false, that it's not the same percentage of men and women, that it is more women. And then can't see the last one, many incarcerated women. Can you bring that up? But the answer is true. Many incarcerated women have been a victim of emotional, physical, or sexual abuse.
And
And
that
that
was
is true.
100%.
Yeah,
Everyone got that one correct.
that is true. But the first one can be true or false. I'm going to say that some of them do present differently, and many don't present differently. Okay. Well, thank you for coming to this podcast, and thank
Thank
you all for inviting
you.
me.
Thank you so much. We were so grateful that you said yes to doing this. Um, we can do questions, but I'm just gonna run through like the last slide. So I'm going to be posting all of this and any of the resources from the presentation onto our Mighty Networks. And I will also send an email wrapping up everything, and you'll have the PDF version of the slides. NJ thank you. NJ we have it in our state. The information will be in the chat as well. They offer free screenings. Thank you so much for attending today's presentation. Let us know how we did. Use the evaluation link. And also, if you are trying to do the CMEs, you need to fill out the evaluation link. That's how we'll get it to you.
And I'm going to sign off now because I'm going to go back to seeing patients. But thank you very much for inviting me, and it was wonderful spending this time with you. Bye bye,
Thank you.
everyone. Bye
Thank you,
bye.
Dr. Bachman.
Thank you,
Have a
Dr.
good day.
Bachman.
Bye
If
bye.
anybody has questions that you want me to ask Dr. Bachman too, you can email me or put it in the Mighty Networks and I'll reach out to her. Here's the Mighty Networks link. It should be in the chat as well. Next, April 8th, we have a session on the basics of malignant hematology. It's our first blood cancer echo, so be sure to be there for that. That has a different link. That's the screening and prevention series. And then a special thanks to the entire team because I would not have been able to put this together and do the CMEs. So thank you to our team. Thank you to our planners and reviewers, Aisa and Kalisha. Thank you. Thank you, Evelyn. Thank you, Dr. Bachman and Ellen. And yes, thank you so much for attending.